you very much for the kind introduction. First of all, I would like to thank Professor Magdi Yaqub and Professor Bono for giving me the opportunity to talk about the Doha experience. I'm going to talk also AF treatment, catheter ablation, and other arrhythmias we encounter in Qatar. So basically, atrial fibrillation in the elderly poses a major global public health burden. It's a progressive disease and little known about atrial fibrillation in our region. It is the leading cause of stroke. Out of 4 stroke patients, 1 of them is due to atrial fibrillation. And the risk is 5 times increased compared to the general population. Also, there is significant mortality associated with it. The death rate are doubled in patients with atrial fibrillation. So today I'm going to outline my presentation. I will be covering those aspects. Number 1, I will talk about the AF management in Qatar and in the region. Dr. Al-Suwaidi yesterday have covered part of it, but I'm going to speak more, and the data will be extrapolated from our Gulf Safe registry. Now, I will be also talking about AF ablation and overall arrhythmias, the Doha experience, and I will also just give you an example of a couple of inherited arrhythmias that we encounter during our daily practice. So the Gulf Safe, it is basically the only multinational Middle Eastern observational AF registry conducted to date. It was the principal investigator is Professor Mohammed Zubayd from Kuwait. The main paper is not published yet. I'm going to present to you today some of unpublished data to share with you the experiences our experiences in the region. So the Gulf Safe, basically, it's an emergency room based, and the objective were to study the characteristic of our atrial fibrillation patient, investigate how they are being managed and their real life outcome. So the methodology paper was published in Circulation Outcome in 2011. The lead investigator is Dr. Mohammed Zubayd from Kuwait, Dr. Wafa Rashid from Kuwait, Dr. Alawi Al-Sheikh from UAE, Dr. Wael Al-Mahamid from UAE, Abdullah Shahab from UAE, Dr. Kadhim Suleiman from Oman, Dr. Ibrahim Al-Zakwani from Oman, Dr. Ahmed Al-Qadimi from Yemen, myself, and Dr. Haytham Amin from Bahrain. So looking at the distribution of the Gulf Safe population, we recruited 1,700 patients with non-valvular atrial fibrillation. They were from 30% from Kuwait, 20% from Oman, 6% from Qatar, 22% from the Emirates, 19% from Yemen, and 3% from Bahrain. The clinical practice in the region is almost similar. Kuwait, Saudi Arabia, which did not take part, Oman, Qatar, UAE, and Bahrain are very similar with regard to the infrastructure and the management of patients. So this is the baseline characteristic of our atrial fibrillation patient in the region. It's strikingly, they are at young age. The mean age is 59 years. They have lots of comorbidities. Almost 60% are hypertensive, 32% are diabetics, and stroke is almost 10%, TIA 3.8%. Also looking at the body mass index, it's almost 40% overweight and 33% are obese. So looking at the management aspect, so the first two things, a physician encountered with regard to the management of atrial fibrillation. Number one, we look at the rhythm management, and number two is the oral anticoagulation. So this is a busy slide here, and summarizes the rhythm management in the region. Out of 1,700 patients, we have observed that the physician in the emergency room, almost 71%, chooses the strategy of rate control. And 80% of these patients, they get hospitalized. The group that they decide they will use a rhythm management, which is around 24%, only 13% of them, they decide to do electrical cardioversion, which is extremely very low in number. And the majority, 86%, they go for the pharmacologic cardioversion. We have also observed like 10%, they had a spontaneous conversion of atrial fibrillation in the emergency room itself. And to our surprise, almost 75% of those patients get also hospitalized. The green are the patients that get hospitalized, like almost 85% of the patients seen with atrial fibrillation in the emergency room get hospitalized, which add a great burden to our bed and cost effectiveness. So the second issue is the oral anticoagulation. This is basically considering this was in 2009 and 2010. We were following the CHAD score. We were observed that physician in AF patient with a CHAD score 0 and 1, where they were at low risk, they were given, started on oral anticoagulant, where they were not supposed to do that. And in the patients with a CHAD score 2 or more, only like 50 to 60% were on oral anticoagulant. In fact, 40% of patients that they were supposed to be there, they did not get the therapy. So basically, this was basically an eye-opener to us here, what we are doing in our daily practice. So the management of AF were very conservative in terms of attempt at restoring sinus rhythm. Rate control was the most commonly used strategy. When they attempted cardioversion, they shied away from the use of electrical cardioversion. And most patients, even the young and low-risk ones with recent onset, they were admitted to the hospital. So I will go switch gears here, and I will talk about our cardiac electrophysiology and ablation, our experience in Qatar. So this is our data from between 2005 to 2012. Basically, we have almost 600 patients, 400 males, and almost 200 females. So there is a 2-to-1 ratio. And looking at the Qatari versus non-Qatari, the non-Qatari are almost 500 patients compared to the Qataris, which is 110. This is not unusual or not unexpected, knowing there were lots of expatriates working in Doha, and this is quite well representative of the population of Qatar. So looking at our cardiac electrophysiology study and ablation, number one ablation is WPW, followed by AVNRT, ventricular tachycardia, and atrial fibrillation comes number 4. It is much less compared to the other supraventricular arrhythmias. In these patients, we have attempted ablation using the architect circle and the first generation cryo balloon. We had lots of recurrence rate. 1 year success rate was around 60%, but majority of them, they recur during their second or third year. To our surprise also, we have extremely low number of patients with atrial flutter. This is one of the commonest, one of the easiest arrhythmias that electrophysiologists would like to ablate, but we are really getting very small numbers of atrial flutter. We have done 100 and almost more than that now of transseptal puncture, and we have no complication, thankfully. We have a good success rate with the supraventricular tachycardia, mainly AVNRT and WPW, with a success rate of almost 96%. Regarding AFib ablation, AFib ablation in our experience falls fourth, but the reason is probably we were conservative in that aspect. But looking at the recent guidelines, where they are been put catheter ablation as almost first line therapy. This has never been before. So in fact, patient with paroxysmal, they could go straight to catheter ablation. So I think there is a trend now toward early intervention in patients with paroxysmal atrial. It has never been before. So in the coming few years, we expect the number of procedures to go up. So our experience here, we have, during the last year, we have used two approaches. Number one, we have used the CARTO 3, which is the first system was installed in the region and in the Middle East. We have done a total of 14. We choose mainly paroxysmal atrial fibrillation to start with. We have chosen the Hamburg approach. 14 patients were involved in this, and all of them are of Arabic descent. Yesterday we were talking about ethnicity. None of them are from the Far East or Southeast Asia. The procedure was double transseptal, point-by-point map of the left atrial geometry, then ostial tag of the right and left pulmonary vein, and then we go ahead with the circumferential ablation. This kind of procedure is quite tedious. It's time consuming. It takes between 3 to 4 hours. We are still in the learning experience. Fluoroscopy time ranges 30 to 55 minutes. We did, out of the 14, 12 patients were in sinus rhythm and out of arrhythmic drugs after 3 months of blanking period. These are the ostial tag, and basically this is an animation where we go and ablate point by point across the pulmonary vein. It is technically challenging, more complex, requires navigation system, challenging to achieve constant catheter stability. I'm sure my colleagues will go in the depth of this in the next presentations. And this is the final result. Basically, then I will go to our second approach. We also we have done 8 patients using the cryo balloon second generation. And it was the first center in the Middle East Qatar was the first center to do this kind of procedure in the region. We recruited 8 patients, and we used the Architect front advance. And basically, again, for interest, 7 patients were of Arab. Some of them are Qataris, and one Pakistanis. 7 patients are in sinus rhythm and out of antiarrhythmic drugs after 3 months of blanking period. Procedure went from, it was varying between 1 hour, 20 minutes to 2 hours and 50 minutes. Fluoro time is much less compared to the CARTO. And we have observed the pulmonary vein potential disappearance within 30 to 50 seconds after the cryo balloon application. And we were able to see the pulmonary vein potential basically in almost 80% of patients. So I think this then we are quite happy with the Architect circle, where it can give us a surrogate endpoint about our result. So this is our cath lab. This is the balloon. There is a dye here. And we will be looking in the monitor for the pulmonary vein potential and then simultaneous disappearance of the pulmonary vein potential. The advantage of this catheter, I'm sure my colleague, they may be talking about it. The Achieve catheter, which has got sensors inside the pulmonary veins, and this is the cryo balloon at minus 50 degrees. Those signals from here are transmitted. We could see an atrial ventricular, and in between we see what we call the pulmonary vein potential, which is the trigger for atrial fibrillation. We see a gradual increase in delay and sudden isolation, which is really, this is an important for us to know, and it will direct us with the success of the procedure. So this is from our lab as well. This is a pulmonary vein potential, and we get the isolation. So basically, my experience has been quite encouraging, and even in talking to my colleagues in the region, I think cryotechnology is quite promising, and it has got a shorter learning curve compared to the. I'm sure many they will be addressed in the next presentation. Now I would like to share with you some of the inherited arrhythmias we encounter in our daily practice. This was published in the American Journal of Emergency Medicine. This is a 30-year-old man with recurrent loss of consciousness. Maybe he's an Egyptian, lost consciousness more than 60 times. And when we saw him, this was his ECG. He had an ECG of Brugada pattern. During his hospitalization, we were doing the routine assessment, and during the tilt table test, he started to lose consciousness on monitor, and ECG did not show any arrhythmias, and there were no change in blood pressure or heart rate. What we observed was having focal seizure, so we attributed that the most likely cause for his syncope is seizure and not Brugada. He also had some runs of short run of atrial fibrillation, this patient. So basically, we discussed with a neurologist and to choose one of the antiarrhythmic drugs, one of the anti-epileptic drugs that may not interfere with the Brugada. So he was started on oxcarbazepine. Following his second dose, he went into a VT storm. He had to be shocked at least 16 times, and the arrhythmias was only settled after being started on isoprenaline. We do see Brugada quite often, at least maybe our specialist here agrees with me. We see 1 or two patients almost every month, incidentally, comes to the emergency room. So I would like to share with you another case which we have seen, and this was published in PACE in 2010. A patient with recurrent ventricular tachycardia as well as atrial fibrillation in patient with the Friedreich ataxia in the absence of any clinical myocardial disease. This was a young guy, 33-year-old, with recurrent loss of consciousness. He had both ventricular tachycardia as well as atrial fibrillation. The investigation was he had normal echo, normal coronary angio, normal MRI, and he had a negative tissue Doppler, no evidence of pericarditis or myocarditis. So clearly this patient was, it's common that they have myopathy, but to have arrhythmia as a presenting is a bit unusual. So he was managed with amiodarone, and an implantable defibrillator was inserted. He had a genetic analysis which showed inotropic expansion of repeat sequence GAA on chromosome 9q13, which I know very little about genetics. Excuse me, probably I will. And this is basically, he was having both wide QRS arrhythmias. Even after implanting defibrillator, he was having wide complex. This is ATP and then converting to sinus rhythm. So my conclusion, in our region, atrial fibrillation affect relatively young people with high risk profile. WPW and AVNRT are the commonest arrhythmias encountered in the EP lab in Qatar. Pulmonary vein isolation using radiofrequency and cryoballoon are both feasible. Many patients received warfarin when they did not seem to be eligible for this treatment, while significant proportion of eligible patients did not receive warfarin. Also, the rhythm management in the ER resulted in a low rate of cardioversion attempt and high rates of hospital admission. Here, analyzing those 2 points, we need to have a strategy in our hospital to design a protocol to address this issue, and maybe having an AFib clinic also that can deal with these issues. Finally, but our future project in the arrhythmia section, we would be starting soon the Gulf ICD registry, and hopefully with all this in mind, we would like to start a genetic testing involving the inherited arrhythmias or the arrhythmia patients in general. Before I finish, I would like to thank all my colleagues that they work with me, Dr. Shahul Hamid, Dr. Sayed, our chief technologist, Dr. Qasim, Dr. Muhammad Khalil, our nurses and technicians and secretary. Thank you very much.